Today we'll be covering Chapter 41. This chapter goes over ocular infections and the causative agents. Ocular infections can range from mild self-limiting conditions to those that are more severe and can also threaten the sight of the patient. Mild infections are some that you're familiar with, such as conjunctivitis or blepharitis, which the eyelids become inflamed. More severe infections that can threaten the sight of the patient include keratitis, which involves inflammation of the cornea, or endophthalmitis, which involves inflammation of the inside lining and cavities of the eye. The surrounding soft tissue, sclera, lacrimal system, and bony orbit are also subject to microbial invasion, and these can be infected by a variety of organisms such as bacteria, fungi, viruses, and protozoa, and they all play prominent roles in pathogenesis of ocular disease. So before we jump into the diseases and the infections, first we need to talk about the components of the visual system. So the components include the eyeball, the muscles, fat, nerves, orbital bones, and the neural pathways that carry electric impulses that are converted to vision. This is a diagram taken from the textbook showing common ocular structures. So on the top diagram, some of the components of interest are the conjunctiva. So you'll see we have the conjunctiva tarsal and the conjunctiva bulbar. So these are the mucous membranes that cover the inside lining of the eyelids and the white of the eye, the sclera. Another important area is the eyelids. So these are the thin layers or folds of tissue in which blinking occurs to protect structures of the orbit. Also helps in lubrication and sweeping of the eye. And then the other important component is the cornea itself. So the cornea is also called the window of the eye. On the bottom diagram, you'll see the retina, which is the light-sensitive neural tissue of the eye. And then you'll see this diagram just also shows a different depiction, a side view of the eye and all its components. As was discussed on the previous slide, the conjunctiva is a mucous membrane covering the inside lining of the eye. It's similar to those membranes in the mouth and nose and constitutes the front line of defense against invading organisms. The tears that keep the conjunctiva moist contain many enzymes and other factors that protect the conjunctiva from microbial invasion. The eyelids, as mentioned before, are thin elastic layers. They are the thinnest skin covering the body. The blinking action of the eyelids and conjunctivae help keep the cornea and sclera lubricated and sweeps away debris and potential pathogens. The eyelashes also act as a filtering and monitoring system that alerts the brain to potentially harmful agents. And then finally, the cornea, which was discussed previously, is considered the window of the eye. Its function is similar to that of crystal on a wristwatch. The internal ocular structures can be viewed through the cornea. The function of the curved corneal surface is to refract, collect, and focus light onto the retina. Additional ocular structures discussed include the orbit that protects the soft tissue of the eye, the lacrimal apparatus that provides tears to lubricate the eye, the anterior chamber that maintains intraocular pressure, and the vitreous chamber that maintains elliptical shape of the eyeball. The uveal tract includes the iris, ciliary body, and choroids, and the retina is the light-sensitive neural tissue of the eye. Like the other organ systems we've discussed so far, the ocular system also has microbial biota that's considered normal. The primary residents include coagulase-negative staph and Crinibacterium species. Organisms that can be recovered from eyes of individuals without active infections vary depending on the patient's age, the season, the location of the patient, and then any underlying conditions. So other organisms that may be recovered include Staph aureus, strep pneumonia, and Haemophilus influenza. The presence of some of these organisms on the conjunctiva and eyelids act as a protective mechanism, inhibiting the invasion and colonization by more harmful bacteria or organisms. Table 41.1 from the textbook gives a summary of the ocular normal biota from non-inflamed eyes. So you'll see at the top the coagulase negative staph make up 34 to 94% of the normal flora. Propionobacterium acnes makes up 40 to 86%, and then Crinibacterium makes up anywhere from 3 to 83%. The remaining organisms have a smaller incidence, but varies from anywhere from 0% to 30%. As mentioned before, normal flora of the eye act as a protective mechanism because they aid in preventing invasion and colonization of pathogens. Discriminating between the normal flora and pathogens is blurred with ocular biota, because organisms responsible for intraocular and corneal infections also include some of the organisms that can be considered normal. So coag-negative staph, propionobacterium, and staphylococcus can be found on healthy individuals, but also on patients who have eye infections. So it's important to differentiate between colonization and infection. So quantitative cultures are helpful in establishing thresholds for these pathogens. Because of their location, external ocular structures and surfaces, such as the conjunctivae and cornea, are frequently challenged by a variety of microorganisms. Whether an infection or damage ensues depends on the structure, immune status, and response of the host, also on the integrity of the underlying tissues and pathogenesis of the invading organism. Important host protective mechanisms include that the epithelium is intact because that serves as a barrier, that tears are able to be produced because those contain IgA, lysozyme, and lactoferrin, which coat bacteria, break down the cell wall, and chelate iron. So as we've discussed previously, risk factors make certain patients or hosts more prone to infection. So some of those risk factors to consider are the age, sex, race, socioeconomic status, behavior, geographic location, occupation, and underlying disease or comorbidities. Several microbes can penetrate the intact epithelium of the conjunctiva or cornea. So those organisms include Neisseria gonorrhea, Neisseria meningitidis, strep pneumoniae, Listeria monocytogenes, and Crinibacterium diphtheria. For most other organisms to enter and establish disease, a break has to occur in the protective epithelial barrier. Once the intact epithelium is breached by trauma, insertion or removal of contact lenses, an intrusion by pathogenic and saprophytic organisms can occur. Many ocular pathogens possess adhesions and enzymes that can aid in adherence, multiplication, and dissemination in ocular tissues. Biofilm production is also a factor in virulence of organisms because this protects them from immune cells and antimicrobials. Table 41.1 in the textbook provides an extensive list of microorganisms associated with ocular infectious disease. The way this chapter is broken down, it summarizes the infections based on the different structures. So the first structure of the eye that we'll talk about is the conjunctivae. So we'll focus on infections of that structure. Conjunctivitis is the most common ocular complaint. It includes all age groups and occurs worldwide. There's actually an estimated 6 million people in the United States that develop conjunctivitis annually, and 1% of primary care visits are related to this condition. Symptoms of conjunctivitis include itching, tearing, a foreign body sensation, discharge, which may be purulent or watery, and hyperemia or increased blood flow resulting in red eye. Red eye constitutes more than 50% of office visits to ophthalmologists, and it's the most common ocular reason for microbiological evaluation. Conjunctivitis may be acute, hyperacute, subacute, or chronic. Viruses are the most common cause of infectious conjunctivitis, and bacteria are the second most common cause. Fungal and parasitic infections are less frequently seen, and uncomplicated acute viral or bacterial conjunctivitis is generally self-limiting and does not require treatment. However, hyperacute infections with Neisseria gonorrhea or Chlamydia trachomatis should be treated. Corneal involvement may follow conjunctivitis and compromise the vision. Chronic infections are more difficult to manage and result in long-term ocular morbidity and compromised vision. Box 41-2 in the textbook summarizes various organisms that can cause conjunctivitis. So you'll see there's a variety of bacteria, viruses, fungi, and parasites that are included in this list. And the bacteria also include gram-negative, gram-positive organisms, and then the chlamydia and related species. There are various treatment protocols for a patient with conjunctivitis depending on the causative agent. So as discussed before, uncomplicated acute viral and bacterial cases are self-limiting and don't require treatment, whereas hyperacute infections by Neisseria or Chlamydia should be treated. Chronic infections are more difficult and result in long-term damage, and the majority of people with allergic conjunctivitis do not seek treatment. Acute bacterial conjunctivitis occurs in both adults and children. With adults, the causative agents are typically Staph aureus, strep pneumonia, Haemophilus influenza, Streptococcus species, or Enterobacteriaceae. In children, the list of causative agents is a little smaller. It's typically Haemophilus influenza, strep pneumonia, or Moraxella catarrhalis. Hyperacute conjunctivitis involves infections with Neisseria gonorrhea and Neisseria meningitidis. With hyperacute infections, there's a large amount of exudate that can run down the face of the patient. This figure shows a patient with gonococcal conjunctivitis, and you'll note the copious amounts of discharge in response to the invasion by the Neisseria gonorrhea organism. Chronic bacterial conjunctivitis is typically caused by Staph aureus, Moraxella leucanata, or enteric bacteria. So this type of infection can be caused by contaminated cosmetics or medications. And the causative agents in that type of infection include Staph aureus, Staphylococcus epidermidis, Crinibacterium species, Pseudomonas aeruginosa, and Proteus mirabilis. Allergic and chemical conjunctivitis can sometimes be confused with microbial infections, so it's important for the clinician to rule this out before deciding if any treatment protocol should be followed. Laboratory tests can assist in differentiating acute, allergic, and chronic conjunctivitis. The specimens requested would be conjunctival scrapings that are collected using a spatula, blade, or sterile swab and plated directly onto culture media and slides. Routine stains can be used, such as gram stain or Gamesa, and culture should reveal the causative agent in most cases. All cases of purulent membranous and pseudomembranous conjunctivitis should have workups, especially those associated with neonate or infant infections. The treatment for bacterial conjunctivitis depends on the severity of the infection. Generally, as mentioned before, it can be self-limiting and resolved without treatment, but in some cases, antimicrobial agents may be prescribed, and that can reduce symptoms and prevent secondary infections. Typically, initial empiric topical therapy is enough to treat the patient. Therapy is sometimes adjusted based on the organism isolated and antibiotic susceptibility testing results. Chlamydia can cause several ocular infections, including neonate conjunctivitis, inclusion conjunctivitis, lymphogranuloma, venereum, and trachoma. Neonatal conjunctivitis becomes apparent within 8 to 10 days after birth, and the infant is infected while traveling down an infected birth canal of the mother. Inclusion conjunctivitis can lead to pharyngitis, otitis media, and interstitial pneumonitis in the newborn. Chronic conjunctivitis with cornea involvement is a consequence of untreated or inadequately treated inclusion conjunctivitis. Lymphogranuloma venereum can occur as a result of accidental inoculation from a genital infection. And then trachoma is the leading cause of blindness worldwide. Direct detection of chlamydial inclusions can be done in scrapings or on impression cytology membranes, and it's generally considered a sensitive method for confirming ocular chlamydia infections. Cultures may be done using McCoy or human epithelial cell type 2 cells, and these may be used to confirm the diagnosis, especially in cases of suspected trachoma. There are also non-culture detection methods such as polymerase chain reaction, direct fluorescent antibody assays, and enzyme immunoassays that are more frequently used to detect ocular chlamydia infections. In addition to these, nucleic acid amplification tests are considered the method of choice because they have high sensitivity and specificity. Once a patient is diagnosed with an ocular chlamydia infection, the treatment includes azithromycin or doxycycline for adults and erythromycin or azithromycin for neonates. So in Figure A, it's showing an example of a patient with inclusion conjunctivitis. So the white spots on the conjunctiva represent pockets of chlamydia organisms in the tissue. On the right, immunofluorescence stain of a scraping from a neonate conjunctivitis confirms the presence of chlamydia. Aside from the bacterial pathogens we discussed on previous slides, viruses can also be a cause of conjunctivitis. Viral conjunctivitis can be present in acute or chronic forms and can vary from mild self-limiting disease to severe destructive infection resulting in impaired vision. Viruses can be transmitted nosocomially, with the causative agent being adenoviruses, and this can be done when it's found on contaminated fluids, fomites, or vesicular fluids. Acute viral infections are attributed mainly to adenoviruses, herpesviruses, or enteroviruses. The adenoviruses are responsible for two distinct ocular viral syndromes, EKC and pharyngeoconjunctival fever, also known as PCF. EKC is a contagious disease and associated with adenoviruses type 8 and 19, but recovery of serovars 7, 9, 10, 11, 14, and 16 has also been documented. PCF is frequently caused by adenovirus type 3 and occasionally other serovars such as 1, 2, 4, 5, 6, 8, and 14. Both of these syndromes are self-limiting and have no specific treatment. PCF lasts about 10 days and EKC can last 3 to 4 weeks. EKC has been known to spread through direct contact, fomites, and physicians, and it's usually responsible for outbreaks in eye doctors' offices and clinics, school locker rooms, or college dormitories. Acute hemorrhagic conjunctivitis, also called epidemic hemorrhagic conjunctivitis, is an acute, short-lived infection caused by either enterovirus 70, Coxsackie A24, and on rare occasions, adenovirus type 11. The onset of symptoms occurs within 8 to 48 hours of exposure, and patients typically complain of pain, sensitivity to light, copious tears, and subconjunctival hemorrhages. This is a self-limiting infection and has no outline treatment. Herpes simplex virus causes a blepharoconjunctivitis that's responsible for the most severe ocular viral infections. This disease usually occurs in young children, and it's important to distinguish between the herpes simplex virus and adenovirus causes because HSV can be treated with specific antiviral medications. Other viruses that have been involved with conjunctivitis include CMV, Epstein-Barr virus, and then patients who have chronic viral conjunctivitis. This picture is an example of acute hemorrhagic conjunctivitis caused by enterovirus 70 or Coxsackie virus A24. Conjunctival scrapings are a specimen of choice in diagnosing viral conjunctivitis. These specimens may be stained with monoclonal antibodies to confirm infection with a viral pathogen, or nucleic acid amplification testing can also be used for various viral agents. The most common pathogens may be grown in cell culture and then serotyped with monoclonal antibodies or using neutralization tests. Currently, there is no treatment for adenoviral or enteroviral ocular infections, so cold compresses may help alleviate some of the symptoms. With HSV infection or varicella virus, orally administered acyclovir can be used to treat severe cases. Although various fungi can be isolated from the uninflamed eye as normal biota, fungal conjunctivitis is relatively rare. The organisms that have been recovered from fungal conjunctivitis include Candida species, Sporothorax schenkii, Coccidioides immitis, Histoplasma capsulatum, Cryptococcus neoformans. To diagnose fungal conjunctivitis, the clinician has to have a high suspicion of a fungal origin, and the laboratory has to be alerted to ensure that proper setup and recovery is available. The laboratory diagnosis includes recovery of organisms on routine media and detection on gram and Giemsa stains. Treatment for fungal infections includes natamycin and amphotericin B ocular preparations that are used to treat the most common infections. Parasitic infections of the conjunctiva is generally rare, but ocular sites are sometimes the secondary complication of a systemic parasitic infection. Loa loa is one of the causative parasitic agents. It's also known as the eyeworm, and it's one of the leading causes of blindness in West Africa. So clinical symptoms of Loa loa infection are caused by the continuous migration of the adult worms into subcutaneous tissue and blood vessels. Onchocerciasis is transmitted by the bite of the black fly and is also leading cause of blindness in Africa, and now it's been seen to be endemic in South and Central America. Recovery and diagnosis of ocular involvement depends on observing and removing the larva and then confirming their presence through either histologic staining or isolating the organism from blood or tissues, or confirming it using serologic testing. Loa loa infection is treated with diethyl carbamazine, so that kills the larva and adult worms, and it's the treatment of choice. The recommended treatment for onchocerciasis is ivermectin, but this only kills the larva and prevents them from causing damage, but it doesn't kill the adult worms. So now we'll move to the next structure of the eye. So we're looking at infections of the eyelids. Infections of the eyelids, also called blepharitis, is not a mutually exclusive infection because it's typically accompanied or presents with conjunctivitis. So conjunctivitis presents as blepharoconjunctivitis. So any organism that can cause conjunctivitis can also affect the eyelids. Staph aureus and coagulase negative staph are the bacteria most frequently isolated from the eyelid margin. So blepharitis usually involves these organisms with low-grade inflammation associated with functional disease of the seborrheic glands. So symptoms of this include scales that attach to the lashes, and then the ulcerations can cause lashes to fall out. So treatment for blepharitis is using antibiotics and/or medicated shampoos. So box 41.3 in the text gives a list of organisms associated with blepharitis. So you'll see there's common bacterial agents such as staph species, group A and B strep, and then Moraxella species. There's other bacteria that can be isolated but more rarely, and those include Bacillus, Haemophilus, Clostridium, and then of course fungi, which are rare, and then viruses such as HSV, varicella, papavirus. 4 types of glands are located on the lids: the meibomian gland, the glands of Mole and Zeiss, and accessory lacrimal glands. Acute infections of the glands of Zeiss or Mole with staph result in external hordeolum, also called a stye. So a stye is an abscess with pus formation in the lumen of the affected gland. So treatment for this includes hot soaks or hot compresses that assist in the continuous drainage of the abscess. Erythromycin or tetracycline may also be applied topically as supplemental therapy. Viruses can also be a cause of blepharitis or infection of the eyelids. So causative viruses include HSV1 and 2, varicella virus, pox virus, and papavirus. So with these viral infections, a vesicle forms on the lid margins, then the vesicle breaks, and that allows for secondary infections. To diagnose this type of viral infection, cell culture can be done, and most cultures from herpes simplex virus can be reported in 72 hours or less. Vaccinia infection results from direct inoculation from a smallpox vaccination, and then ocular warts are produced by members of the papillomavirus family. Fungi can be a cause of infection of the eyelids, but these are more rare. The causative agents are typically Candida species or Blastomyces dermatitis. But with these fungal infections, it's usually a complication of a systemic disease. Parasites can also be a cause of blepharitis, but these are also less common, and they can include cutaneous leishmaniasis, trypanosomiasis, Loa infection, and Dirofilaris. The crab or pubic louse can also cause infection and itching, and would be treated with medicated ointment or shampoo. The next structure of the eye we discuss is the cornea. So microbial keratitis is considered a true ocular emergency since few organisms can invade the intact cornea. Keratitis caused by microbial pathogens results from trauma to the eye. These types of infections can be severe and vision can be compromised, and then it can lead to blindness. The common causative agents include Pseudomonas aeruginosa and Staphylococcus aureus. Risk factors for developing this type of infection include persons who use contact lens, especially those with extended wear, persons who have undergone LASIK surgery, and then an individual who has experienced eye trauma. Figure A on the left shows you the severity of a cornea infection. This patient experienced corneal melt as a result of bacterial invasion of the eye. On the right, figure B is showing streaks of Staphylococcus aureus from an infected cornea. The enzymes produced by some of the strains of Staph aureus and Pseudomonas aeruginosa can liquefy the cornea within 48 hours of infection. This is a figure of Pseudomonas aeruginosa growing on a daily wear contact lens. So you'll see the contact lens in the middle and the colony spreading surrounding the contact lens that has been laid on the agar surface. This diagram shows bacteria recovered from contact lens and contact lens solutions. So you'll see the green portion is Pseudomonas aeruginosa, and that makes up a larger portion, 18% of infections, along with Serratia marcescens, making up another 18%. And the largest group, making up 35%, is unidentified gram-negative rods. So the causative agent of most of these types of infections are gram-negative rods. This diagram is showing a corneal graft tissue that's been infected with a Mycobacterium species. Laboratory assistance with diagnosing is required in all cases of keratitis. Ideal specimens for examination of smears and for culture are corneal scrapings, and these specimens would be collected by an ophthalmologist. Material should be inoculated directly onto culture plates and slides and then sent immediately to the lab. Scrapings for stains can provide the physician with an early indication of the causative agent and assist in selection of appropriate therapy. The cornea may also be invaded by metastatic spread from the conjunctiva or systemic lesions, so other specimens may be useful in diagnosis. Therapy for keratitis is often selected on the basis of the results of the smear examination, or it may be chosen empirically for the most likely pathogen. Management includes topical antimicrobial drops or ointments supplemented with oral or systemic antibiotics. Herpes simplex virus is a cause of viral keratitis, and it's the leading cause of infectious blindness and ocular morbidity in the U.S. Worldwide, approximately 1.5 million new cases of herpes simplex virus keratitis occur each year. Herpes simplex virus can result from direct inoculation or reactivation of the latent virus, but most ocular lesions are caused by herpes simplex virus 1, although herpes virus simplex 2 has been recovered from cases involving infants and adults. Laboratory diagnosis includes direct detection using monoclonal antibodies, DNA probes, commercial kits, PCR, and/or cell culture. Treatment of herpes simplex infections include debridement, topical antivirals, and possibly corneal transplantation. Box 41.5 from the textbook gives a list of the various organisms associated with keratitis. So although herpes simplex virus is discussed more in the textbook, there's several other viruses that can be associated with keratitis. This table is one from a study in southern Florida showing the prevalence of herpes simplex virus 1 in keratitis viral infections. So you'll see there's an 86% incidence of HSV infections in keratitis. Fungal keratitis is usually a result of opportunistic infection or saprophytic organisms. So a person becomes infected once trauma has introduced the organism with exposure to soil or plant material. Laboratory testing includes stains using Giemsa and Calcifluor white preps from the scrapings of the advancing edges of the ulcer. So these stains would be observed for hyphal elements and yeast to confirm the identity of the causative agent. Treatment for fungal keratitis includes amphotericin B, natamycin, nystatin, and imidazole. Causative agents of parasitic keratitis include Acanthamoeba, Naegleria species, and Falcamphius species. Patients usually develop these infections as a consequence of injury or exposure to contaminated water, contaminated contact lenses, or soil. So a couple risk factors include wearing contact lenses while swimming in contaminated water. In addition, not following proper protocol in disinfecting and storing contact lenses can lead to biofilm formation by bacteria. This can then, in effect, provide an environment for certain amoeba, such as Acanthamoeba. Laboratory testing includes obtaining scrapings that are placed on nutrient agar. So a few drops of a heavy suspension of E. coli or Enterobacter aerogenes is used on the plate as a food source for the amoeba. The scrapings are collected and then placed into cell cultures. Treatment of parasite-related keratitis includes protocols such as debridement, topical solutions, or corneal transplantation. Acanthamoeba keratitis is difficult and includes debridement in early disease. There are no amoebicidal agents that are currently approved, but patients can be treated with a combination of drugs such as topically applied solution supplemented with neomycin drops. The last type of keratitis discussed is microsporidial keratitis. So this is seen in immunocompromised patients such as those with AIDS, and it's a disease that's appeared fairly recently. Microsporidia is usually associated with contact with bees or other insects, and the organism is an intracellular spore-forming protozoa. In humans, both ocular and non-ocular diseases have been reported. The causative agent of microsporidian keratitis is Microsporidium species. These appear round or spherical shaped, ranging from 1 to 20 micrometers in size when viewed microscopically. Spores of Microsporidia may be detected with several stains, including hematoxylin and eosin, gram stain, Giemsa, acid-fast, or calciflower white stains. The diagram below shows a gram stain revealing the oval cyst of Microsporidia species. The next structures of the ocular system that we'll discuss are the sclera and episclera. The sclera is composed of tough collagen fibers, and few organisms can penetrate the strong protective coat. Scleritis is usually a local manifestation of systemic connective tissue disease, such as rheumatoid arthritis or systemic lupus, or it may be a result of contiguous spread from adjacent ocular tissues. Scleritis may present as acute, which is also known as pyogenic, or chronic. The episclera is a thin layer of elastic vascular tissue that overlies the sclera. Inflammation of this tissue is called episcleritis. Episcleritis is more common than scleritis and has an undetermined cause in about 70% of the cases. Laboratory diagnosis for infections of the sclera and episclera include collection of tissue or discharge from the site and plating on routine and special media for common and infrequent isolates. Treatment is dependent on the organisms, but surgical intervention may be necessary to slow down the progression of infections. The next structure covered is the orbit of the eye and the infections associated. Preseptal cellulitis is an infection of the eyelids and soft tissues surrounding the orbit. This infection is considered a medical emergency in children since it can lead to blindness or even death if not treated immediately. Laboratory workup for preseptal cellulitis include gram stain and then cultures, both anaerobic and aerobic. Predisposing factors for preseptal cellulitis include trauma, lower respiratory tract infections, impetigo, and hepatic diseases. The more commonly recovered causative agents include Staph aureus, Haemophilus influenza, strep pneumonia, and strep pyogenes. Treating this type of infection involves using broad-spectrum antibiotics for coverage for the above-mentioned bacteria. Orbital infections can also be extensions of bacterial or fungal sinus infections. Organisms that initiate sinusitis can also cause orbital cellulitis. The majority of causative agents of orbital cellulitis are typically bacterial, and they include organisms such as Mycobacterium, Nocardia, and Actinomyces species. Saprophytic fungi can also be involved in these infections, as well as parasites such as Trichinella or Echinococcus. Aspirates for smears and cultures are collected and placed onto slides by an ophthalmologist and sent immediately to the laboratory. Stains from tissues and/or aspirates can lead the physician to an early indication of the causative organism and assist in the selection of appropriate therapy. Systemic therapy should be instituted as soon as the appropriate culture samples are collected. Therapy should also provide coverage for both aerobic and anaerobic pathogens. Next, we'll discuss infections of the lacrimal apparatus. The lacrimal glands, accessory glands, puncta, canicula, tear sac, and nasolacrimal duct together are known as the lacrimal apparatus. Disorders and infections of the lacrimal apparatus are caused by blockage or underproduction or overproduction of tears. Inflammation of the lacrimal or tear sac is known as dacryocystitis, and it's the most common infection of the lacrimal apparatus. Infections are usually seen in infants and are associated with obstruction of the nasolacrimal sac. Symptoms associated with this infection include tearing, discharge from the eye, an inflamed sac, and also pain. The causative agents of dacryocystitis include Chlamydia trachomatis, Aspergillus, Candida, and Actinomyces. This figure shows a child with dacryocystitis in the left eye. There are several microorganisms associated with infections of the lacrimal apparatus. So you see the above bacteria are some of the ones we mentioned, along with viruses, fungi, and parasites. Dacryoendinitis is inflammation of the main lacrimal gland that may be infectious or non-infectious. Organisms are seeded into the gland through the bloodstream. Blunt trauma also predisposes the gland to infection. Bacterial isolates typically include Neisseria gonorrhea, Staph aureus, and Streptococcus species. Chronic bacterial infections of the gland involve tuberculosis, syphilis, or leprosy. Mumps and infectious mononucleosis are the common viral infections associated with the lacrimal gland. Subclinical or inapparent infections have occurred in patients with herpes simplex virus, varicella zoster virus, CMV, Coxsackie virus A, and echovirus. Other viruses have also been implicated in lacrimal gland infections, and these include measles and influenza viruses. Caniculitis is a disease found exclusively in adults. Symptoms include low-grade inflammation that affects the lower caniculus. Usually a purulent cheesy material can be found that's expressed from the lumen. Causative agents of this infection include bacteria, fungi, and viruses. The bacterial infections usually consist of mixed aerobic and anaerobic species, with the aerobic causative agents being Staph aureus and Streptococci. Anaerobic organisms include Actinomyces, Propionibacterium, Cutibacterium, Nocardia, and Fusobacterium. The fungal isolates that have been involved include Candida albicans and Aspergillus species. Materials for microbiological evaluation include drainage material, pus, and exudate. Direct smears for bacteria and fungi should be prepared from these specimens. The causative agents and fungal hyphae are often seen in large numbers. Infections with mixed organisms are also evident, so media should be inoculated so both aerobic and anaerobic organisms will be recovered. Treatment for caniculitis includes systemic antibiotics, topical drops, or ointments. The next structure discussed is the intraocular chambers. Infectious endophthalmitis is associated with inflammation of the intraocular tissues or cavities and is a result of complications of surgery, contiguous spread of infection from infected tissues, use of contaminated medications, or penetrating ocular trauma. Endophthalmitis may also be caused by installation of contaminated eye drops and implantation of contaminated biomaterials. It's a serious and sight-threatening ocular infection, and any organisms that gain entry into the inner chambers of the eye can result in disease. The causative agents include bacteria, viruses, fungi, and parasites, with the most common bacteria being Staphylococcus epidermidis and other coagulase-negative staph. Box 41-7 in the textbook gives a summary of the different organisms that can be involved in this type of infection. Aspirated anterior or vitreous fluids or washings of the vitreous chambers would be the specimens submitted for laboratory testing. Rapid recovery and identification of invading organisms, complemented by early specific aggressive therapy, are important to prevent loss of useful vision and preserve the internal ocular structures. Because the volume of the specimen submitted is generally small, intraocular fluids aspirated are plated directly onto selected media. Chocolate agar should be used and other media selected for other pathogens after consultation with the ophthalmologist. Drops are placed on slides for gram stain, Giemsa, or cauliflower white stain. Vitreous washings can also be filtered through a Teflon filter and sections placed onto the selected media. Treatment for endophthalmitis includes injection of intravitreal antibiotics or antivirals. Figure A is showing a section from a filter used to concentrate vitreous fluids. Once the fluids have been filtered, the filter is sectioned and the sections are placed on selected media. Figure B is showing growth of Curvularia species from intraocular fluids on a filter section. And figure C is showing Burkholderia cepacia on a filter from a vitrectomy specimen. The next section discusses biofilm-centered ocular infections. We discussed biofilms previously, and as was mentioned, they can form on a variety of foreign materials. So in this chapter, we're discussing how biofilms can form on contact lenses, cornea implants, and shunts. Microorganisms in biofilms are causative agents for a variety of infections, and these include contact lens-associated and crystalline keratitis, late onset postoperative endophthalmitis, and orbital implant infections. Complications associated with biofilm formation are chronic infections and then decreased vision, including blindness. Table 41-2 in your textbook summarizes the ocular diseases associated with biofilm formation. So they list the clinical diseases, the biomaterial or biofilm origin, and the recovered or common organisms seen. So there's several different clinical diseases, but ones that we would focus on are the contact lens associated keratitis or endophthalmitis. So you'll see with contact-associated keratitis, the recovered organisms are typically Pseudomonas aeruginosa, Staphylococcus aureus, and coagulase-negative staph. Endophthalmitis, when biofilm forms on intraocular lenses, is frequently caused by coagulase-negative staph, with Staphylococcus epidermidis being the most frequent, Propionibacterium, Candida albicans, and Staph aureus. The figure below is showing a yeast biofilm that has formed on a contact lens. In culture, the specimen grew Candida albicans. Now we'll move on to laboratory diagnosis of ocular infections. The key to proper collection of ocular specimens are similar to those for any other microbiological specimen. Materials or scrapings for culture should be collected as soon as possible after the onset of infection. So that would be within 24 to 48 hours for bacteria and 3 to 7 days for viruses. And the specimen should be collected before any antimicrobial treatment has been administered. The sample should be collected from the actual site of infection. For example, conjunctival and eyelid cultures are inadequate to assess corneal involvement. Any ocular fluids, tissues, sponges, and other surgical materials must also be submitted, but done in sterile leak-proof containers that are properly labeled. The culture should then be inoculated with the material directly onto the appropriate media. If swabs are submitted, Dacron or calcium alginate swabs should be used, but noting that alginate swabs are toxic to some viruses. Smears are then done to detect organisms present for presumptive treatment. Figure A on the left is showing the procedure to obtain concretions by expressing them from the canicula of the eye. So a concretion is a hard solid mass that's formed by local accumulation of matter within the body. So in this person, the concretion has formed on the whites of the eye, and it's being expressed to be obtained for laboratory workup. On the right is a figure of a gram smear in which concretions are smashed and stained on a slide, and you'll see this gram stain reveals gram-positive slender branching rods. So this organism that was isolated was Actinomyces. Conjunctival and corneal scrapings, intraocular fluids, and aspirates are collected by an ophthalmologist using a spatula, blade, or sterile swab, and they can be used for direct examination with a smear. So typical stains that would be used are gram stains, Giemsa, and calcifluor white. Fluorescent stains can also be used to aid in identification. Membranes are used to filter large amounts of fluid collected to concentrate the sample to subsequently perform a smear. Table 41.3 provides a summary of stains that are routinely used in ocular microbiology and appropriate applications of each procedure. The gram stain and Giemsa stains should be used for any suspected cases of bacterial infection. Calcifluor white stain should be added to rule out fungal or parasitic diseases. And fluorescent or acid-fast stain is used to detect the presence of acid-fast organisms. This figure is showing a Giemsa stain of conjunctival epithelial cells with chlamydial inclusions. The black arrow is indicating one of the chlamydial inclusions. The Giemsa stain can also be used to provide information on the types and numbers of inflammatory cells present and the condition of the epithelial cells. Most bacterial and fungal ocular isolates can be recovered on chocolate and blood agar when incubated at 35 degrees Celsius and 5 to 10% carbon dioxide. Additional plates should be incubated anaerobically if indicated. Also, for patients who are suspected of having chlamydia or viral infections, cell culture may be required to be completed, in which specific transport media should be used to collect the samples. Biopsy tissue can also be submitted to the laboratory and is typically minced or ground to complete the workup. The media is then inoculated with the ground tissue to isolate aerobic or anaerobic organisms. If amoeba are suspected, 2 non-nutrient agar plates should be inoculated. Table 41.4 in the textbook is a helpful summary of the different clinical presentations we discussed on previous slides, along with the media to inoculate, so the minimum requirements of media you would use, and the stains. So if you look, you'll see that for most of these infections, chocolate agar would always be included along with sheep blood agar. And then depending on the possible causative organism, additional enriched media may be used. This figure is showing an example of a sabroid agar plate with a mold and a yeast growing. So this patient had a mixed fungal keratitis. So the top superficial layer of the cornea was infected with the mold. So you'll see the culture here growing organisms that look spready and hairy versus the bottom that were growing a yeast. So this is Candida species, and these colonies appear white and smooth. Quantitation of growth is important when assessing ocular infections. Samples from patients receiving antibiotic treatment may have reduced growth, which should be taken into consideration when evaluating the culture. Special considerations are involved in corneal and intraocular fluid cultures. So traditionally, corneal scrapings were inoculated in a C-streak fashion. Each row of C-streaks represents a separate scraping of the corneal ulcer. Molecular techniques have also been used to identify causative organisms. So direct antigen detection and nucleic acid amplification testing often provide rapid and accurate identification, especially to confirm clinical diagnosis for difficult or unusual pathogens. These methods may be ideal for detecting organisms in ocular samples due to the small volumes submitted. Figure A on the left is showing a contact lens and lens solution that has been cultured on 5% sheep blood agar, and it's surrounded by growth of Pseudomonas aeruginosa. Figure B in the middle shows C-streaks growing a pigmented and non-pigmented Serratia marcescens. And then figure C on the right is showing corneal scrapings and the proper C-streak technique that represents separate corneal scrapings. This figure shows Staphylococcus epidermidis that has been recovered from vitreous fluids. So this sample has been plated differently than the C-streak techniques. The samples have been inoculated as a drop on the blood agar plate, but alternatively they can be inoculated onto chocolate or blood agar and allowed to dry, or they may be streaked for isolation as you would routine microbiology specimens. Eye drops are easily contaminated when improperly handled. Inappropriate handling can contribute to ongoing ocular diseases and initiation of new infections. Contaminated medications should be sent to the laboratory for culture in addition to obtaining specimens from the eye itself. As mentioned previously, contact lenses are major risk factors for microbial keratitis. Keratitis associated with contact lenses is being documented with increasing frequency. The sources include contact lenses and contact lens solutions and cases. Box 41.9 in the textbook lists the organisms recovered from these sites. Contamination of soft contact lenses is usually caused by failure to follow the manufacturer's recommended procedures or by poor hygiene. Here is table 41.9 with the list of the various organisms. Replacement of diseased corneas is a common operation. The new corneal tissue is obtained from donors within 24 hours of death and is preserved in Makary-Kaufman or Dexol medium. After surgery, the container with the medium and remaining corneal rim is sent to the laboratory for culture. Bacteriologic evaluation of the donor tissue is important in reducing the transmission of host-carried disease to the recipient. The most common pathogens isolated in this type of procedure are gram-positive organisms, so the most frequently isolated ones are Staphylococcus and Propionibacterium acnes. This last slide covers briefly a topic that's noted in the textbook regarding special procedures for recovering ocular pathogens. The first procedure mentioned is the lysate test. This is used to detect the presence of endotoxins in tissues or fluid. If endotoxins are present, the substance will form a gel clot to indicate a positive result. This test is used more often in the manufacturing setting for the solutions for contact lenses. The other procedure discussed is using sabroid agar with gentamicin for fungal isolation. So this procedure can be used in both the routine microbiology lab if ocular specimens were received, or in special laboratories if a more extensive fungal workup is needed.